All right. So I thought I would just go over drugs that we use in the cath lab that I'm finding myself using very regularly. So this is not uh, really thought out. So I'm just going to start naming them off, and maybe I'll just give my thoughts on them and like what I like to know, like in my head, or like at least maybe I'll quiz myself. And if I don't know something, I'll look it up while I'm sitting here. So a lot of so in the cath lab, oftentimes we'll use what's called moderate sedation. Um, and with moderate sedation, it's generally two drugs. You're going to use a benzodiazepine, and a opiate. So you'll use oftentimes like the go-to is Versed or midazolam, which is a rapid-acting benzodiazepine. You'll give generally a milligram starting. You start with a milligram of Versed, and the concentration we use is just 1 to 1, 1 milligram per 1 ml, and usually we'll pull up two milligrams and 2 mLs from a vial, and then we'll use fentanyl. So Versed fentanyl or fentanyl Versed is kind of the cocktail of choice for moderate sedation. And generally, I'll start with a milligram of Versed and 50 milligrams of fentanyl. We'll slam it down and see where we land. Generally, now if the person's really large, it might not work. It might not affect them as much. It's going to distribute. If more body mass to distribute, they're not going to be as affected. If they're a frail, nice old little lady who's only 40 kilos, 1 in 50 might be too much. It might shut her down real good, and you don't want to do that. So depending on the size of the patient, also I think I talked about this in a video, but smoking and alcohol will affect how the fentanyl Versed works. So if they smoke or they drink, you might have to give more medication. So those are two medicines we use in the cath lab. Another two big medications we use are anticoagulants, or antithrombotics, whatever you want to call them. The two biggies are heparin, and we'll use Angiomax. So generally we don't switch back and forth, but you can. They're both a little different. So heparin comes usually the concentration we use is 1,000 units per mil, and when we give heparin, we're giving it to anticoagulate while we're placing a stent in the coronary artery. So with heparin, we're gonna measure something called an ACT. ACT stands for activated clotting time, and we're gonna give the heparin at a dose rate between usually 60 and 70 units per kilo, sometimes more, sometimes less. But that's usually kind of where it lands, somewhere in the 60 to 70 units per kilo range. So if they're 100 kilos, you're going to give 7,000 units or 7 mLs of heparin in a bolus, and then in 5 minutes you'll get an ACT, and depending on where your ACT is at, you want it over 300 seconds. So if it's not over 300 seconds, you may have to give it a second bolus. If it is over 300 seconds, to maintain that steady state of 300-second ACT, you're going to give 1,000 more units every 20 minutes. And that's kind of how we give our heparin. So you give the initial bolus when we decide we're going to be giving a stent. And once your ACT is above therapeutic, above 300 seconds, you're going to give 1,000 units every 20 minutes to maintain that ACT above 3,000 so they do not clot off while you're placing stents and stuff. So that's that one. And then another one you use is Angiomax. The generic name is bivaluridin. It's an IV drug. The way this one works is different than heparin. With heparin, well, yeah, it's different. It's the same as that you give a bolus, but then you're also going to put it on a drip. So you get a 50 cc bag of Angiomax. You'll pull off a bolus dose of it, and then you'll run the rest of a drip at generally the dose is 1.75 milligrams per kilo per hour. And so, you pull generally between 7 and 15 mLs of drug, and I think it generally comes in 5 milligrams per mil. and I don't know what, I have a little chart that I'll look at. Okay, what's their kilos, and that's how many mLs I'm pulling, and so then I'll pull it off and give it, and then I'll run it as a drip. So that's another one. Angiomax is different than heparin because it doesn't have a reversal. Heparin has a reversal. So the reversal for heparin is pyridamine sulfate. So you'll give protamine sulfate if you want to reverse them, which you don't want to reverse somebody who's getting stents. But that's a reversal. Angiomax doesn't have a reversal. Heparin has a pretty short half-life. I think it's a few hours. But Angiomax has a really fast clearance time. So Angiomax is going to be off in like 30 minutes usually. Like it'll be out of the system really quickly. So you don't want to just turn them off without giving like an antiplatelet like Plavix or aspirin. And I'll go over that stuff in a minute too. So Angiomax is a little bit different. It also is more effective than heparin, kind of, because it acts in two different areas of the clotting cascade. So just off the top of my head, I think Angiomax, I think it prevents prothrombin from converting to thrombin, I think, and it prevents fibrinogen converting to fibrin, I think. So let's look it up. Let's look it up really quick. Mechanism of action for Angiomax.
According to Wikipedia, it is
okay. I'm just going to mute this. Okay, synthetic peptide. Let's see. Inhibits both circulating clot-bound thrombin. Boom. Inhibiting thrombin-mediated platelet activation aggregation. Quick onset and acting at half short. Yeah, so elimination half-life is 25 minutes, like I said. Inhibits thrombin-mediated platelet activation. So clot-bound thrombin protects you from. So there's two parts of the clotting cascade. Basically, thrombin and I think fibrin formation prevents that from happening. Here it comes. Let's see. Highly specific inhibitor of thrombin. Inhibits both circulating clot-bound thrombin while also inhibiting thrombin-mediated platelet activation and aggregation. Has a quick onset and short half-life. So that's what's nice about it. It's quick on and quick off, but you got to keep it running until you get those post-stent meds in. So let's move right into more drugs. So after you've given your anti-thrombotic, you keep them from clotting IV with your heparin or Angiomax, and we've put in a stent. Now we're going to make sure that they take medications by mouth that are going to maintain a patency of that stent. So generally, we only use 3, really. We use aspirin, 324, right? So 4 baby aspirin, and coupled with either 600 milligrams of Plavix, which is a bolus dose, or 180 milligrams of, oh man, I'm tired. I'm losing my brain. Brilinta. So Brilinta, Plavix, they're competing antiplatelets. They both are, drugs that you use. One's expensive, one's not expensive. One works better if you have COPD. One works better, I think, if you're diabetic, something like that. Anyways, the doc's going to decide which one he wants. Does he want Plavix or does he want Brilinta? But both of them would come with 324 of aspirin as well. So you're going to give all those medications after they kind of wake up. You want to get those meds down. So those are some medications you use in the cath lab. So some more medications we use. Another one's like cardiac. We use some cardiac medications. All our code drugs. If patient codes, we're going to be using Epi. We use the Epi 1 to 10,000, 1 milligram in 10 ml, just code push drugs. So that's the code one, and you can slam that IV if they're coding, or if you lose their pressure, you can kind of push that and get their pressure back fast. So we'll use that medication. We'll use something called phenylephrine, and our phenylephrine comes in an IV push dose presser, and that comes in 1 milligram in 10 mLs, so 100 mics per mil. You can get between 100 and 200 mics every Q5 minutes, and that's an obligate vasoconstrictor. And so if the patient already has a problem with their LV function and they already have a poor cardiac output, and then you increase your afterload by constricting the vessels. You're going to put increased load on the heart, and you might actually burn the heart out faster. So you want to be careful with cardiogenic shock and neosynephrine or phenylephrine. So another short-term name is Neo. But if you're in a pinch and you need to get the pressure up because their coronary perfusion sucks, you can give 200 mic bump of that, and it keeps your pressure up for 5 minutes or so while you're stripping out a levo drip or stripping out dobutamine, and usually dobutamine or dopamine levo. So moving on to those ones. So let's just talk about those two. Well, let's see any other cardiac stuff. You have amio, amio 300 if it's for refractory VFib or VTAC. We don't usually put amio drips. We don't usually do an amio drip. I don't usually give DILT either. We have DILT, but usually it's intra-arterial for vasospasm. You get 5 milligrams of DILT if we go radial access. If we get the radial access, they might give a cocktail of heparin, DILT, nitro is kind of the cocktail that they'll give, and that prevents vasospasm, clotting, vasodilatation with the nitro, and then that's kind of spasm, clotting, and vasodilation. So those are some other drugs. We'll give nitro a lot of times, intracoronary nitro. So if the patient's having vasospasm, the doctor might order like 100 micrograms of intracoronary nitro, and that's just vasodilator. And nitro generally works on the venous system, but if you're getting it directly into the coronary, it's going to dilate the coronary out. You will see maybe a drop in pressure too from that. What else? You can give atropine for bradycardia. So if you notice that their heart rate's getting low, generally if it's below 45, for me it's a problem. So if they started out at 60, throughout the case they start to drop lower, lower, lower. I see them drop 45, 43, 42. I'm going to mention something and maybe start with 0.5 milligram atropine. Generally, atropine doesn't work if you have a third-degree heart block. So if you have a complete heart block or a third-degree heart block and you don't have any connection between your SA node and the AV junction, if you're not able to get signals through from your SA node to your AV junction to your Purkinjes, and you have a complete dissociation of your atrium and ventricles, generally atropine is not going to work because atropine works on the vagus nerve, and the vagus nerve innervates at the SA node and the AV junction. So if all that sucks and not working, atropine